Hello, thank you for joining us today for our Peripheral Arterial Disease presentation. My name is Laura Love, and I'm the Community Health Education Specialist at McLaren Bay Region. We are excited to have you join us for today's program. During today's podcast, as questions come up, please feel free to comment, and they will be addressed at the end of the presentation. I'm honored to introduce Dr. Nicolas Mouawad, vascular surgeon with McLaren Bay Heart and Vascular at McLaren Bay Region. Welcome, Dr. Mouawad.
Thanks so much, Laura, and thank you all for joining us today on our presentation on peripheral arterial disease. So my name is Nick Mouawad, as Laura said. I'm a vascular surgeon at McLaren Bay Region. We're going to talk about peripheral arterial disease, more commonly known as PAD. Why is PAD so important? Well, it's really a public health concern. More than 1 million people in the United States develop symptomatic PAD every year, but only 10% of people with PAD show significant symptoms. Around 25% of these patients undergo proper treatment, and it's very important to have appropriate referrals in order to be able to get appropriate and proper treatment in a good amount of time. But more importantly, PAD, or peripheral arterial disease, I feel is not always an appropriate term, because peripheral arterial disease is also a surrogate for central arterial disease, which can mean disease in your heart, which can cause heart attacks, or disease in your carotids or your brain, which can cause stroke. So a lot of patients with PAD have concerns for heart attack and for stroke. So let's look at some of these numbers. As we spoke about earlier, around 10 million people in the US have PAD, and it becomes more problematic as you get older. 2 times people get PAD as you get older in life. So every 10 years, every decade, the rate of PAD doubles, and around 100 to 150,000 people per year get some sort of surgery to fix these blockages or narrowings in the arteries of your legs. So you can see there to the screen left, the older you get, the higher chance of PAD, and it's more commonly seen in men than in women. Again, I want to push on this a little bit, because as you get older, there's a higher chance, or what we call incidence, of patients getting PAD. People with high blood pressure have 2 times the risk of PAD. Smokers have 2 to 10 times increasing risk of having PAD. And then patients that have diabetes or significant trouble with their sugar control can have 3 to 4 times the risk of PAD. So why do we keep worrying about patients getting PAD? Well, because it's more commonly as you get older, and the United States population is getting older. I mean, that's a testament to the healthcare we're able to provide. We're able to keep people alive longer, and that's great. But we have to worry about things that happen at the extremes of age. Why is it a serious healthcare issue? Well, as I just said, people are living longer, and so the rising incidence of diabetes have led to an increased number of patients with PAD. And people that have PAD can have problems, like I said, with their heart or with their carotids, which can cause heart attacks and strokes. So it's really, really important that we detect this early so that we can treat it or manage it earlier on to avoid things such as heart attacks, strokes, gangrene, and ultimately, God forbid, amputation. As I said earlier on in a few other slides, patients that are diabetic have an increased risk of death and trouble from PAD. We see just around 15,000 or so patients per year die from PAD. Again, a lot of amputations are done per year because people don't have this detected early on. So 150,000 PAD-related amputations are performed in the US and Europe per year. That's a staggering number. And then patients that have severe trouble with their legs or blockages in the arteries of their legs can have blockages in the arteries of their heart, again, causing heart attacks and stroke. And so that's very, very important. We talk about this ABI, which I'll refer to a little bit later on, but that talks about narrowing or blockages in your arteries. And so we know that if you have severe forms of blockages in your artery, you have a higher chance of death, or I guess a lower chance of survival. So the more trouble you have, the more important it is to have early detection so we can manage the disease of your arteries, be it in your neck, your arm, your belly, your legs, or your brain. Some risk factors for PAD. Well, we discussed it a little bit earlier, but patients that have high blood pressure, that have high cholesterol, that have diabetes, again, a lack of exercise, a sedentary lifestyle, it affects males more than women, but women are also very much affected by this. And then, of course, smoking. So these are main risk factors for PAD, and it's important that we detect it early on. So what are the symptoms? How do you know that you have PAD? Everybody always asks this. PAD, again, is narrowing or blockage in the blood flow to your legs primarily, but you can see it anywhere else. And so how do you know that you have it? The most common cause or the most common complaint is trouble or painful cramping in your legs with walking. Usually you walk a certain distance and you get trouble in your calves or your thighs. You stop and the pain goes away. You start walking again and it comes back on. I feel like most of my patients say they notice trouble walking to their mailbox and it's too painful and they have to stop on the way there or on the way back. Of course, coldness to your legs, coolness to your legs, a change in color. If you find that you're losing hair closer to your feet, brittle toenails, and no pulse or a weak pulse in your legs, these are signs of PAD. In men, erectile dysfunction or impotence. And then very importantly, again, if you have sores or wounds on your leg or you have pain in your legs all the time that don't go away, even when you do nothing, those are very, very concerning signs of PAD and actually advanced signs of PAD. But importantly, 50% of people have no symptoms. So you could have blockages or narrowings in your arteries, but you not notice anything at all until sometimes it may be too late. And again, here in this circular kind of pie chart, you can see 50% of people that have PAD are asymptomatic. That means they have no trouble at all. They don't know that they have it. And so the onus is for us to be able to detect it early and see what we need to do, if anything. 33% have atypical leg pain, and then you can see there 15% have what we call claudication. That's pain when you walk that goes away when you don't, when you're at rest. And a very, very fortunately, very small proportion of patients, 2%, have what we call critical limb ischemia, which means sores or wounds that don't heal or pain in your legs even at rest. And that's very, very dangerous. So I want you to be aware. Many people mistake the symptoms of PAD for something else. They sometimes think it's arthritis. They think maybe it's from their back, some nerve compression. And a lot of times PAD goes undiagnosed or unnoticed by healthcare professionals. So make sure you see a vascular surgeon or a vascular specialist, somebody that specializes in the management of arteries, whether it is in your legs or your arms, your belly, or your heart, or where it may be. Patients, again, with PAD have a higher risk of heart attack and a higher risk of stroke. And left untreated, PAD can lead to sores and wounds that don't heal, which can ultimately lead to gangrene and to amputation. I don't want you all to get worried. I'm just going to show you on the next slide the type of things that I see. So just be careful with these patients with regards to gangrene. I'll show them to you on the next couple of slides. I'm sorry about that. How do we diagnose PAD? Well, you need to be seen by your vascular specialist. We do an examination to make sure that your pulses are strong in your feet and your arms. A lot of times we'll use a blood pressure cuff to make sure the blood pressure in the ankle is appropriate, and that can be done in what we call our vascular lab. We can use an ultrasound machine to look at the artery or to hear the artery with a Doppler. And then sometimes you have to have a CAT scan or what we call non-invasive imaging to give us the shape of the anatomy of your arteries. And you can see this on the next slide, excuse me. So this is obviously one of my patients, and you can see this is the blood flow coming from the level of their kidneys and their heart down both their legs. And you can see some blockages and narrowings in this type of advanced imaging that we do to make sure that your blood flow is okay. The goals of treatment are, number one, to make sure that your quality of life is better. You may be getting older, you want to play with your grandkids, you want to golf, you want to take a trip down to Arizona or Florida, so it's important to increase your quality of life and remove the pain that you have behind your legs if it's an issue. Of course, we want to avoid gangrene, which can also, of course, avoid amputation. And then we want to make sure that you don't have any blockages or narrowings in other parts of your body, such as your heart or your brain, which can cause, obviously, a heart attack or a stroke. And again, I don't want to get anybody worried, but in the next slide, I'll show you these are the type of patients that I see. So take it easy. I know it's a little bit before dinner, but these are the type of patients that I see with gangrene of their toes. And we don't need to be in this situation. Early detection and seeing your vascular specialist earlier on can allow us to be able to treat this before it becomes a problem. Okay, so this is dry gangrene of the right foot. So when to refer? Well, if you're having recurrent trouble with your leg over and over and over again, you can't seem to get somewhere, you should come see a vascular specialist. If you go any of our screening programs or we see any severe disease on any of your tests, such as your ultrasound or that ABI test with the blood pressure cuffs, you should be seen by a vascular specialist. And any sores or wounds that are non-healing, those absolutely need to be seen by a vascular specialist because that means you don't have enough blood flow to maintain perfusion to your legs or your feet. So why refer to a vascular surgeon? Well, it's because we deal with this all the time. Vascular surgery studies the natural history, the medical treatment, the minimally invasive treatment, and the traditional open surgical repair for patients with PAD and any blockages or narrowings of the arteries, anywhere in the body, as a matter of fact. Your vascular surgeon wants to partner with you so we can come up with the best treatment plan for you together as a team. So this gives you the most comprehensive management, whether it's medical, whether it's minimally invasive, or whether it's open or complicated surgical. And again, early referral or an early detection is key to collaborate with your vascular surgeons for better outcomes for you. I mean, we're here for you. So how do you treat PAD? And I get this question all the time. So primarily, there's three main prongs: medicines, minimally invasive interventions, such as a procedure, or something that's more complicated or maximally invasive, if you will, like open surgery. We want to make sure that you're taking your medications appropriately. Good blood pressure control, make sure that your diabetes is under control, take your baby aspirin, take a cholesterol pill, which is called a statin, stop smoking, and be as active as you can with a healthy lifestyle. These are very important for the management, not just of the arteries of your legs, but of your heart and of your carotids of your brain. So it's very important to have good medical management. But now I said everybody needs surgery. The patients that need surgery are people that have severe lifestyle limiting trouble with activity. So you really just can't do the things that you want to do. You can't enjoy your life. And that requires an open discussion with your vascular specialist or vascular surgeon. People that have pain at rest, so you're having pain in your legs at rest even when you do nothing at all, or any patient that has a non-healing sore or wound. Those require relatively urgent vascular evaluation to make sure that the blood flow is restored to your legs to ensure no gangrene or ulceration or God forbid, amputation. These are one of our older patients, but you can see here, these are the old traditional method of dealing with a blockage. If you have a major blockage in your leg, sometimes it's too difficult to get through that blockage. And what we do is we do what's called a bypass, kind of like a bypass on your heart, but it's a bypass on your leg. We get around the large blockage by diverting your blood flow from one part of your leg, usually from the hip, to either below the knee or to the level of the ankle. So this is open bypass surgery, which is a traditional option for treating that. And vascular surgeons are obviously very well equipped at dealing with this because this is the kind of things that we do day in and day out. But here at McLaren Bay, we do a lot of complex, minimally invasive restoration of blood flow, particularly to the legs. And again, this is a surgical picture, but all the black there is a flow of blood. And you can see actually in the lower part of the picture, there's really no black there at all. And that's because there's a blockage behind this patient's knee. And so they're not getting any blood flow to their leg. And so we need to restore the blood flow. Could you do a bypass for this? Of course. But that's more complicated for the patient. It's a prolonged stay in the hospital. So we are very aggressive at doing what we call endovascular or minimally invasive type procedures to restore blood flow. And so you can see there in the middle portion now, there's a black line all the way down, which is restoration of the blood flow down the leg, because like I said, blood looks black under the x-ray machine. And on the far right of the screen is the disease, what's called the plaque, atherosclerosis, or the plaque that we removed minimally invasive with some advanced surgical or procedural techniques. And that's some of the treatment that we do here at McLaren Bay. Again, this is another picture that you can see to the top left. You can see a black blood flow at the top of the screen, but then below it's all these squiggly lines because there's no real blood flow going down the leg. And then in the middle picture and to the screen right, you can see now there's a big highway of blood all the way down the right leg. And at the bottom part of the picture is you can see the amount of disease or the plaque that was removed in a minimally invasive manner to restore blood flow to this patient and restore function and restore, like I said, blood flow to their leg. To the screen left, you see what we call endovascular, which is minimally invasive restoration of blood flow, primarily to the legs because we're focused on that today. But we do this the same day. You go home the same day. Under our care, you go back to regular activity within a day. And generally speaking, I see the patients in 3 to 4 weeks' time back in the office to make sure that everything is the way it needs to be. Of course, we're available 24/7 if there are any questions or concerns, but it's all taken care of the same day if it can be done. For some patients, minimally invasive options are just not possible. There's too much blockage, it took too long to be seen, and it's much more complicated. And those patients tend to have either open bypass surgery or open removal of that disease that you saw earlier, which is called plaque. And so generally speaking, patients will spend 2 to 4 days in the hospital and then they can return to their activity after an evaluation by therapy, because usually it's much more involved and you need a couple of extra days to get back on your feet or feel more comfortable. But again, we'll see everybody in 3 to 4 weeks. And of course, at any time in between, should there be any questions or concerns in the meantime. For us at McLaren, obviously, we have multiple service areas. I mean, I'm located here in Bay City, which is we do a lot of complex vascular work here with the restoration, like I said, of flow to the neck, the belly, and the legs. But we have a large catchment area, and a lot of us manage these type of patients depending on where you live. And again, if we could be of any service at any point, or you have any questions, give us a call at Bay Heart and Vascular here at McLaren Bay Region, and we're always happy to help out and assist. Again, it's very important. This is a partnership between us as physicians and you as patients to be able to come up with the best treatment plan for you, whether it's medical, minimally invasive, or open surgical. And with that, Laura, I think I'll take some questions if people have some questions up front.
So much great information, Dr. Mouawad. I've always learned a lot when you do our presentations for us. And I think we do a lot of great programs on stroke and cardiovascular disease, but I think we learn a lot when we talk about peripheral arterial disease. And I think it's just great for our community to learn more about PAD, because I think there's just so much information out there about PAD. And when you talk about it, it just makes it so much easier to understand. So thank you for taking the time to do that. And we do have a number of questions, so let's get started. Looks like Grace has a question. Will PAD cause stroke, which I just mentioned, and how?
Yeah, thank you, Grace, for that question. Again, PAD, when we say peripheral arterial disease, it's a surrogate marker for blockages and narrowings in other part of the body. So we generally refer to PAD as blockages in the legs, but for patients that have PAD in the legs, yes, the onus is on the physician or the provider to be able to check the arteries of the neck, the heart, the arm, and so forth to make sure there's no blockages there. Just because you have PAD does not mean you have a higher chance of having a stroke, but that means, or it's concerning that you may have blockages in the arteries of the neck, so you should be checked out to make sure that you don't have a significant blockage there.
That's great. We have another great question. What's the gold test for PAD?
So it depends is the answer, as with many different things. When we're looking for what we call a physiologic issue, it's the ABI, or the blood pressure cuff, because that gives us the amount of blood pressure and blood getting to the foot. But when we're looking at the anatomy, so where the actual blockages may or may not be, a CT scan can be very, very helpful. The gold standard evaluation of your arteries is what's called a catheter-based angiogram. So kind of like a heart cath, but a cath of your legs. And that's the gold standard for looking at blockages and narrowings. But of course, that's invasive. And so we want to avoid any invasive treatment first by getting as much of the information non-invasive, such that we can plan something if it needs to be done.
That sounds wonderful. Our last question is from Elena. Does everyone with PAD require surgery? And what does recovery from PAD surgery look like?
Great question. So the short answer is no. Patients that have, actually most patients that have PAD do not need surgery. The goal of PAD treatment is to ensure appropriate risk factor management and modification. So making sure you have a healthy lifestyle as much as possible, stop smoking, better diabetic control, good blood pressure control, and so forth. The patients that absolutely need to have surgery for PAD are patients that have, or people that have pain at rest, or those that have non-healing sores or wounds. Those patients absolutely require something done, because that means that just at rest, you don't have enough blood flow to sustain life to your tissues. And that's why they're dying with sores or having gangrene and so forth. So those patients absolutely require that. But most patients, in fact, do not require surgery or intervention. Mostly it's a supervised exercise program, and sometimes we can even prescribe some medications. And like we spoke about in some of the later slides, not everybody requires a hospital stay. If they're done minimally invasive, you get to go home, generally speaking, the same day. If it requires open surgery, those require usually a couple of days stay in the hospital.
New technology is amazing, isn't it? Seriously, when we can do same-day technology, same-day surgeries, that we don't have to stay in the hospital. That's just amazing to me. I've been here 26 years, and the technology and the science just changes daily, I swear. So I'd like to take this opportunity to thank you for sharing your time and knowledge with us today, Dr. Mouawad. I know you've got a million things going on, and but I know you've also said that you would check back on our Facebook, and if you have any other questions out there, that you would be happy to answer those. You're always very good with our community.
Absolutely, Laura. Thank you guys for inviting me. Like I said, this can be a very scary thing for you all out there, but this is something that I deal with day in and day out. I see that I deal with this every single day. So if you guys have questions or concerns or worries, be in touch with us. I'm sure one of our healthcare providers or myself will be happy to take care of you at any point.
That's wonderful. Thank you so much. I'd like to take this opportunity to share some information with you about a free community screening for peripheral arterial disease that we are going to have coming up soon. As Dr. Mouawad was discussing, we will be screening for PAD with a simple test called ABI, the ankle brachial index test that he was discussing. The screening is scheduled for Thursday, October 7th from 8 to 11 a.m. at McLaren Bay Heart and Vascular here in Bay City. To make your appointment, please call toll-free 1-877-411-2762. For more information, you can log on to mclaren.org/Bay-Region and check out our upcoming events. And yes, Dr. Mouawad will be there at that screening. Thank you again for joining us today. We really appreciate your time and watching us and learning more about PAD.